Welcome, everyone. I'm Albert Wu, and it is my great honor and pleasure to introduce the annual Sam Shapiro Lecture for our Center for Health Services and Outcomes Research. Let me say a word about Sam Shapiro before I get on to Dr. Bindman. So Mr. Shapiro was an early researcher in public health policy, and he spent his career studying the effectiveness of medical treatments in large populations. So in some ways, there are many similarities. Dr. Shapiro, who only became Dr. Shapiro when he earned an honorary doctorate from Johns Hopkins, I think in the 80s, earned a Bachelor of Science in Mathematics from Brooklyn College, and then later a degree in Math and Statistics from Columbia and from George Washington. In the 60s, he became director of one of the early HMOs, the Health Insurance Plan of Greater New York. And at the time, he got interested in the application of mammography. Did it improve survival for women who did it reduce mortality for breast cancer? That work became really one of the early and best known demonstrations of the effectiveness of breast cancer screening. He then came to Hopkins in 1973 as the director of this Center for Health Services and Outcomes Research. Actually, it was then the Health Services and Research and Development Center. And he helped attract really hundreds, ultimately, of students to the department and to the center. He, as I said, he earned an honorary doctorate from the department in 1998. Karen, were you responsible for that? Or maybe maybe Don Steinwachs was, who succeeded Sam as director of the center. And so it's very appropriate that we have today as our visiting professor and guest, Dr. Andrew Bindman. Andy is a general internist, and he is a professor of medicine and epidemiology and biostatistics at UCSF. He's also the director of the California Medicaid Research Institute, which I think is a collaboration between the university and the state department. And he's also attached to the Institute for Policy Studies, I think, that is named after Phil Lee at UCSF. He's devoted what is now surprisingly, I guess, a long career in studying quality of care, and particularly the quality of care for vulnerable populations, and has been very interested and increasingly interested in translating research into policy. So he started out more or less in Boston as an undergraduate at Harvard. He was a medical student and resident at Mount Sinai Hospital, where we were actually interns together. He was then a clinical scholar, Robert Wood Johnson Clinical Scholar at Stanford, where we were also fellows together. So I certainly had good luck of being able to hang on to Andy's coattails. He ultimately became the chief of general medicine at what is now the Zuckerberg San Francisco General Hospital. You can see the similarities in some ways to our own Bloomberg School of Public Health. He's been vice chair of population health for many years and director of this institute. He he got the Washington bug. He was an RWJ policy fellow for energy and commerce for a year in the House of Representatives. He was senior health policy advisor for the Office of Health Policy of HHS from 2011 to 14. And he worked to establish new Medicare payment codes for chronic care management, transitional care, and again, so there is that research to policy. He was director of the Agency for Healthcare and Research and Quality. Many of us rejoiced because he was the best director that we could remember in recent years, but he was director from 2016 until January of this year. He's now returned to UCSF, and I'm very pleased to introduce our colleague and my good friend, Andy Bindman.
Well, thank you very much. That was a really lovely introduction, and it's so nice to be here among so many friends and with an opportunity to meet so many others. There's such a great synergy of energy and focus among folks here at Hopkins as there is at UCSF. And I must say that one of the pleasures of being the AHRQ director was getting to know Johns Hopkins quite a bit more, because there's really a very special relationship between Hopkins and AHRQ, both related to some of the work in safety, but across a variety of areas in health services research. So it was a real pleasure, and I found there was tremendous synergy of the activities at AHRQ with so much of the great work that goes on here at Hopkins. So thank you so much for this invitation and a chance to come and chat with you all. I was saying to Albert walking over here, it's kind of a special time in one's life when one gets thrown out of the government, because one has a few things that other people find interesting and you no longer have any inhibitions about telling them. So I will try to share some of what I've observed, and also will welcome your questions afterwards, and don't hold back. So it's good. It's very cathartic for me to be able to share. So let's talk. So we're living in interesting times, which apparently is a good thing, to be able to live in interesting times. We are finding our world, science, a bit under attack. We're learning new terms like alternative facts. There's questioning of certain kinds of science, particularly in the areas of things like climate change research. And we're also have learned about, through the president's budget, ideas to perhaps decrease federal support for research. And so this is something that we're all grappling with who work in this area of science. And of course, this is leading to some to take action. In fact, this Saturday, many of you may be aware of or participating in. I will myself be marching on Saturday in Washington as part of the March for Science to really promote the engagement of science as part of an important part of our society. I think there's also important messages for us all about how do we communicate our enthusiasm for science. We probably all need to learn how to do that more effectively, and I'll come back to this message a little bit later in my talk, because I do think that we need to be both advocates for science, but also learn how to communicate science in ways that it can be effective. Now, this idea of science under attack is not completely new to those of us who've worked in health services research. Health services research has actually been a target for decades. There's been questions raised off and on for quite a long time about the need for public funding and the role of health services research. It often gets formed in the shape of, can't the market address the things that you are raising about how to make healthcare work better? And I think that's an important question that we will also come back to through this talk. And a lot of the focus and the questioning about public funding for health services research has been focused on the Agency for Healthcare Research and Quality, AHRQ. It has really been something that has been discussed actively at different times about whether there's a need for a budget for an agency like this that does this sorts of work. And for those who don't know AHRQ's history, AHRQ was established as a federal agency in 1989. It actually happened during a Republican administration. And AHRQ is currently one of 8 public health service operating divisions. Its original mandate was really to identify and eliminate unnecessary variation practice. It was, when first authorized, one of the ways the tool seemed to do that was to develop guidelines to give physicians clear recommendations about how to practice in a way that would eliminate unnecessary variation in practice. But as you may know the story, that some of those guidelines ran into the recommended practices of certain providers, and probably the most visible example of this was when a group of back surgeons were unhappy about the recommendations that AHRQ made about the need for back surgery at the rate it was being done for back pain, and they organized and recommended to Congress that Congress eliminate the agency that at the time was under the name of the Agency for Healthcare Policy and Research. And so after quite a bit of work by many in the health services community and my predecessor at the at AHRQ, the director, John Eisenberg, at the time in the 1990s, was able to rise AHRQ out of the ashes of AHCPR, and the agency was reformulated with the policy part dropped from its name. Also, the guidelines part dropped from its activities, and patient safety inserted into a primary focus of the agency's work. And this is the last time that the agency has been authorized, was in 1999, and it's still functioning under that authorization. AHRQ's mission has changed a little bit over time, but has pretty much captured a lot of the themes that are in its current mission statement. AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. Those are probably words that you will all recognize from very influential IOM report about improving the performance of the healthcare system. Reports like Crossing the Quality Chasm highlighted these sorts of themes, and these have been reflected in multiple reports. So those are key essential aspects of the healthcare system that AHRQ attends to, but AHRQ also does this work by working in partnership within Health and Human Services and with external partners to make sure that the evidence is understood and used. And I think it's this last aspect that I really am going to underscore as a part of this talk, because I think this is what is so essentially unique about AHRQ and its role within HHS, to attend to this aspect of not just formulating knowledge and evidence, but making sure that that knowledge is understood and utilized in a way that it can make a difference with end users such as frontline clinicians. Now, how does AHRQ do its work? It has kind of three main pillars of how it approaches its activity. AHRQ certainly invests in research, gives out grants and so forth to investigators to develop new knowledge through research. It also has really developed the standards that are understood and utilized about the most rigorous ways to synthesize findings from different research projects to form a synthesis of evidence in a clinical area. And that's been a real hallmark of AHRQ's work for a long time. And that evidence synthesis was part of the foundational parts of when AHRQ used to issue guidelines. AHRQ still does this work on evidence synthesis, but now that work is often handed off to other entities like professional organizations, specialty groups, and so forth, to ultimately develop the guidelines from that evidence. It's also the basis for how the U.S. Prevention Services Task Force puts together and issues its guidelines related to prevention and so forth. So research and evidence are a key aspect of the work. AHRQ is also very involved in teaching and training of healthcare systems and professionals to make use of the evidence. This is probably most developed in the area of patient safety and has really been a hallmark of what many people recognize about AHRQ's unique work. And then finally, AHRQ is involved in generating measures and data to monitor progress for its work, and so that there are key data sets that have really catalyzed work in health services, such as the MEPS data, the Medical Expenditure Panel Survey, the HCUP data, which is the federation of all of the discharge data sets from virtually all the states in the United States, and a growing number of emergency department data sets and so forth. And this has been also key for being able to, the National Quality Report and the disparities reports that really help us know the progress that we're making with regard to the performance of the healthcare system. As I say, probably the area that has gotten the most visibility is certainly from my experience of going over to Capitol Hill when I was the director at AHRQ, that the area of patient safety is the one that I think is probably most easily recognized to many end users. And while this progress depicted here on this slide is not uniquely attributable to AHRQ, AHRQ I think has been an important part of the process of making improvements in patient safety with key partners, including many people here at Hopkins. You have a very renowned, the Armstrong Institute, and the work of Peter Pronovost and many others in improving patient safety has been a key aspect of making progress in these areas. But really to highlight, between 2010 and 2015, when the Affordable Care Act put in place penalties for hospitals related to hospital-acquired conditions, there's been a 21% reduction in those as measured by AHRQ, estimated 125,000 lives saved, 3 million patient harms avoided, and estimated $28 billion in savings. So a very significant return on investment in improvements in patient safety. Still a long way to go, but AHRQ was really instrumental in funding research about how to improve patient safety, played a role in educating health systems how they could make improvements, and then in monitoring improvements over time. And so this really captures the three ways that AHRQ contributes to the work. Now, despite what looks like a very rosy outcome of the investments that AHRQ has made, AHRQ has continued to face an uphill battle. There's been continuing challenges to fund the agency. Very slow growth in funding at AHRQ. Currently, AHRQ's funding is about 1% of the funding of the NIH. And in 2016 alone, there was a $30 million cut in what had been a budget of $364 million per year appropriated by the Congress, was cut to $334 million. And in this current administration's budget recommendations, I think many of you know that the President has recommended moving AHRQ as an independent agency and moving it into the NIH. And I think these are all issues that raise challenges for the field as a whole. And it caused me to do some self-reflection when I was the AHRQ director, and as I continue today following that time period, to think about, what's this all about? Is this something that's problematic about AHRQ, or is this something broader about the field of health services research? And what can we learn as we reflect on where we are as a field? And perhaps is there a strategy for us to think about how we move forward in a more productive way? So as I would think about some of the where we were as the AHRQ director, I really thought that there were three key issues that I think were undermining some of the progress that perhaps could be made in our field, and I want to reflect on those a little bit with you. First, I think our field is in the midst of a bit of a diaspora, and I'll talk a little bit more about what I mean by that. I think that this diaspora is contributing to us losing our unifying story of what we're trying to accomplish, and that by not having that unifying story, we're having a challenge of connecting our story with stakeholders who can be unified with us and help to communicate that story to Congress or others who could support our work in this way. So a diaspora is a term that's often associated with a scattering of a population whose origin lies within a smaller geographic locale, or the movement of a population from its original homeland. And in this story that I'm telling you, I guess AHRQ in many cases was the homeland for health services research. At the time in 1989 that it became a federal agency, this was a very significant time in the development for health services research, that it was elevated to this level. And as the entity that was doing that, AHRQ was really the main entity and was able to help to cultivate the story for the field about what its agenda should be, to set priorities for funding, to harvest the information from that research investigation and so forth to make progress toward particular goals. But what has happened over time is that health services research has seen investments grow, but they've been scattered among multiple entities. And I think that this has, in many cases, undermined the ability to be able to have a unifying story for the field that is critical of being able to have a shared narrative and a way of communicating to support the field. So if you just look at 2016 alone, AHRQ, as I mentioned, had an appropriated budget from the Congress of $334 million. At the same time, PCORI, which was authorized under the Affordable Care Act through the PCOR Trust Fund, had a budget of over $500 million for comparative effectiveness research, a field of activity that was actually started at AHRQ, as many of you know. CMMI, which was another entity that was born out of the ACA, the Center for Medicare and Medicaid Innovation, which invests in demonstrations of health delivery system innovation. Again, another area of activity that was begun at AHRQ, was funded at an average of about $1 billion a year. It was $10 billion over 10 years. And even the NIH, which historically was not engaged in health services research, has grown its portfolio in health services research to where it was spending about $1.5 billion in 2016 alone on health services research activity. So this represents certainly a significant growth of investment in the field. But as I mentioned, I think that what's happened is that the dispersed funding among these different entities has really led to a diffusion of responsibility and competing agendas among these different entities, which has, I think, in many cases undermined the engagement of the field with stakeholders who are excited by and eager to disseminate the story about the impact that the field is having. One of the things that, as the AHRQ director, you do by statute is also to serve on the governing board of PCORI. And so I had a lot of direct experience of hearing the story that that board was telling about what it perceived to be the agenda of its funding versus the story that I would hear told to me by the National Advisory Council to AHRQ. And I also had opportunities to visit on several occasions to the NIH to hear about what it thought it was doing with its funding related to health services research. And I guess I would just tell you that the Venn diagram overlap was both confusing and hard to articulate as a single plan. And I think that this is very challenging to be able to, if we can't communicate among ourselves, to be able to then share with others to really convey the impact of our work. And I think that this is really something that needs to be addressed in a very significant way if we are to make progress going forward. So how do we try to recapture a shared vision, a vision that could be shared by the researchers engaged in health services research, and also a story that we can build in conjunction with stakeholders who could benefit from the performance of the research in the field. I think this is a critical aspect of being able to really move our field along. I shared with some of the students just a little while ago, and have shared with others, that as the AHRQ director, I visited Capitol Hill with great regularity to try to convey the story of AHRQ. And you know, I think that I certainly felt welcome by both sides of the aisle to be able to engage in that. But what they often told back to me was that they rarely, if ever, heard from stakeholders about the value of what AHRQ or any of the health services community is providing that they should continue to invest in, or that they were confused about that. And I could often identify that confusion because they would often tell me about programs that I should learn about that often turned out to be things that AHRQ or others had funded in health services, but that our stories were crossing and that they weren't clear, and that we weren't doing the same job as, say, what the NIH was able to do when they would bring in groups of patients who had certain clinical problems and could tell the story of how the NIH had done discovery that had saved their lives and so forth. And so we have not, I think, successfully developed a storyline with stakeholders that have really helped to reinforce that with policymakers. So I'm going to share a little bit about what I think some of our shared stories should be about, and I don't mean to say that I have the exact right story down. I just think that it is a story that we could consider being our story, but I think we have a work to do as a community to make sure we know what our story should be. I think we'll let the install happen later. And in some ways, I think it's a story that's been around for a while that we haven't taken as seriously as we need to. Again, this is my belief of what is a significant story that we need to address, but really probably my main point is that I think we need to develop a shared story. But let me say a little bit about this. I think that it was John Eisenberg, who was the director at AHRQ in the late 1990s, who told me about there being this evidence gap of about 17 years between when evidence is formed and when it actually moves to the front lines of care. And now advancing forward about 17 or even more years, that gap still exists, or to the degree that we understand it, it still exists. Now, we have much more powerful communication tools today than existed in the late 1990s, early 2000s, but there are still significant reasons for why evidence is formulated and yet it does not move to the front lines of care. And this deprives patients who could benefit from treatments, and it probably contributes quite significantly to disparities in care as the dissemination of new evidence occurs on the basis typically of resources as opposed to on the basis of need. And so that new technologies, new treatments, new modalities of care are being allocated on the basis of resources rather than need is going to widen disparities over time. And so to me, a critical story of what health services research needs to be able to do is to narrow the gap between evidence and improvements in healthcare delivery. And just to give an example of this and the problems that we create for ourselves, this is an institution I know well, UCSF, and you can go onto the website and find this page I took a picture of here. So that if you're a woman of a certain age and you're trying to learn whether you should get a mammogram or not, you might learn that, gee, some experts at UCSF who are part of the Department of Medicine and who participate in the U.S. Prevention Services Task Force recommend through the Department of Medicine website at UCSF that you probably can start getting screening mammography at age 50, and every 2 years is probably a good interval. On the other hand, if you happen to go to the radiology web page at UCSF, you'll learn a different story, which is how dare you wait beyond the age of 40, and of course you should get this every year at the latest. And so my point is not to ridicule UCSF. I haven't specifically looked at the Johns Hopkins website with regard to this, but I have looked at several other institutions. I was at Penn a week or two ago, and they had a very similar kind of issue. And that is that we see health systems basically not functioning in an integrated way in terms of the messages that they're sharing with their patients. And so while we may have enthusiasm for the idea of incorporating patients in shared decision-making, you can imagine the challenge this creates for patients that how can they engage in shared decision-making if the doctors can't even agree on what it is that the evidence is that they're supposed to be making a decision based on. And this problem of the shortcomings of the healthcare system has really been identified and articulated. Someone who's done this very well that many of you in this audience I'm sure know is Mark Smith, who was former president and CEO of the California Healthcare Foundation and was the leader of a Institute of Medicine report on the healthcare system, in which he pointed out really the challenges of our healthcare system and its ability to adapt and really incorporate evidence and meet the needs of patients, even though we have these tremendous resources of generating evidence and we have communication tools to try to make these improvements in quality and cost efficiency and so forth, that we're kind of underperforming in terms of putting these things together. And based on those kinds of observations and the work of the Institute of Medicine, the concept of a learning healthcare system has evolved. And this is the idea that really we need to think at an organizational level about how do we make our healthcare systems better able to take advantage of the evidence that's being generated and moving it to the front lines of care. I have said that one of the things that I observed about AHRQ was that it does incredible work at generating evidence, but that I feared that in many ways that AHRQ's work could run the risk of turning AHRQ into an evidence museum in which tremendous knowledge is gained and synthesized, but that we were not doing an adequate job of moving it to the front lines of care where it could really make a difference. And this idea of a learning healthcare system is really about how do we transform healthcare systems to better make use of both generating, adopting, and applying evidence to improve care. And so why is this issue, this opportunity so salient now? What could really make it possible? And I do think that there are several trends in the environment that make it possible for us to make this transformation today. One is that healthcare is rapidly consolidating. I'm sure you're seeing that here at Hopkins and are participating in that in the same ways that we are in San Francisco. Large systems are becoming much more prevalent. The concept of a doctor functioning as a solo practitioner is diminishing, and increasingly doctors are part of organizations. And being part of organizations creates the potential to share resources that can allow for more efficient generation of new knowledge together and adoption of new knowledge together. And there are also tools, of course, to help make that more possible. The emergence of things like electronic health records, which are growing in their availability and to power to support such an effort. And then the final key ingredient is the payment changes that are underway, that are making these organizations responsible not just for the quality of care, but for the cost of care that is provided to populations of patients. And so this is creating now an organizational imperative and opportunity to really learn from evidence and apply evidence in a different way than existed when practitioners were working in more isolated ways and were working under a payment system that reinforced payment for volume rather than for value. And just to give you some feel for the degree to which physicians are consolidating into health systems, some of the work that was underway at AHRQ while I was there was really trying to map physicians to health systems and understanding the degree to which this was happening over time. This map depicts that there is, of course, variation around the country in this, but overall about a third of physicians are part of health systems. That places like the upper Midwest are further along in this, as is the Northeast to some extent. The South, not as much, but there is a rapid consolidation of physicians into health systems, into organizations that now have a growing responsibility for cost of care and are increasingly sharing the tool of the same electronic health record and so forth. And this opportunity has been recognized in part by the research community and is in fact embedded within one of the last pieces of legislation that was signed during the Obama administration. The 21st Century Cures Bill, which included many provisions, but really is going to, I think, fuel the use of digitized data to support faster, better, and less costly research. The FDA is now required by law to look at real-world evidence generated through things like electronic health records to make approvals for new indications of medications and for post-market surveillance and so forth. And so the use of this data for research is going to grow, and some have talked about this as a national system for evidence generation, or EVGen. And really this will spur what some have referred to as moving data to knowledge, D to K. But I guess I would say that to achieve better health, it's not sufficient to just have moving knowledge to practice, moving data to knowledge, but we also have to move knowledge back into practice. And that feedback loop is something that is still not sufficiently developed, and to me is really the agenda that health services research needs to address head on. And so the way we're going to do this is we're going to learn from the movies. Many of you, I think, know this story from going to the movies or from reading the book. This is the story about a baseball team out in my area, the Oakland A's, in which the general manager, Billy Beane, who was depicted by Brad Pitt in the movies, we should all be so lucky. Basically, this was a baseball team that did not have the budget of many other baseball teams, didn't have the budget of the New York Yankees or the Boston Red Sox, and so Billy Beane took a risk in a sense. He didn't have to invent anything like data analytics, but what he had to do was to be smart enough to bring this data analytics that was increasingly available through fantasy sports and the statisticians who were developing new statistical techniques to predict which young prospects were likely to turn into stars at the major league level. Because the way baseball teams typically spend their money is by they make a lot of investment in young players, and if they bet wrong, then they've blown a lot of their budget. And so using these data analytics and bringing them into the operations of the team was the magic of what Billy Beane, the general manager, did. He brought data analytics into operations. And if you think about it, in healthcare, we've got a lot of the same thing. We've got researchers who have done a lot of the same data analytics going on the research side of our organizations. You've got them here at Hopkins, we have them at UCSF, Harvard has them, so forth, but they aren't merged. They aren't integrated in the way that sports teams have. And the story of this is that the Oakland A's actually came very close to winning the World Series through this technique, even though they were under-resourced relative to the other teams. But the other teams notice this, and it isn't just the Oakland A's anymore that do this. It's basically all of professional sports have moved toward bringing data analytics into their operations of how they run their business. And this is really the challenge for us in healthcare, is to think about how to take that leap of incorporating data analytics that are so prevalent among researchers at many of our organizations and making it part of the day-to-day activities of what we do. And I think there are sort of three key areas that are fundamental to doing this in health system learning. One is related to adopting the external knowledge that organizations like AHRQ and others develop in terms of synthesizing evidence and making sure that it is systematically being monitored and adopted by health systems so that it's up to date. I think what we're also seeing, and I'm learning more about as part of my visit here today, is the ability to generate new knowledge from the clinical data and other data that are available in these health systems. So learning from the actual patients that are cared for by organizations. And then the third key piece is applying this knowledge in a systematic way. So instead of it just being that a particular clinician learns about some new evidence or generates some on their own and does it just in their own small practice, but actually making it systematic and addressing the variation in that across the organization so that it's consistent. And the goal of all this is not to have that every patient with the same clinical problem be treated exactly the same way. It's that the information relevant for that patient is communicated in a consistent way to the patient, regardless of where they come in contact with the organization, so that the patient can bring their own values in communication with the clinician in a way that they can personalize their care. Right now, as I showed you in that example of mammography, we can't even assemble the information to allow the patient to be able to do that. So there still will be differences in choices that patients will make based on their own values and so forth, but we need to be more consistent in understanding the evidence that's relevant for that patient so they can engage in that process. And I think if we do that, we can move Moneyball into medicine ball. I think this is actually something that is critical for us to be able to do. We need to learn how to do this as an organization. And when I've shown this before, one of my colleagues said, "You're just doing this because you want Brad Pitt to play you." And by the way, it's more likely it's going to be Bruce Willis. Nonetheless, I do think it's important for us to be able to convey this kind of simple message to be able to help others to understand what we can offer and do in the health services world. And so, there is many aspects of this, of being able to move information in this kind of way that it can be more actionable. Clearly, a lot of it has to do with things like data analytic tools to be able to generate new knowledge about prevention, treatment, and delivery models, and to learn from the clinical data that are available in our health systems and so forth. It's also about, timely determination of the relevance of external knowledge to your own patient population. I've shared, my practice has always been at San Francisco General Hospital, and we have always had a very rigorous journal club there where the clinicians get together and we talk about the latest research published in the New England Journal and so forth. But the meetings almost always end the same way, which is, well, that's a really interesting study, but it was done in a bunch of elderly white men. And by the way, Andy, we take care of a lot of young Latina women here, or name the group that's different. And so that there's a real barrier around the external generalizability because people perceive that the patients are different. We need to develop ways of understanding more quickly the patient population from research and how it applies to our own patient populations, to be able to map that in a way that we can more quickly understand the relevance of new evidence for our own patients. And then we need to have tools that can help us to evaluate the variation and how that knowledge is being applied to patients in our own system, to identify when that variation is driven because of patients' values or it's being driven because of something that the provider just prefers to do. I do see, as I've gone around the country talking to different health systems, both in my role at AHRQ and subsequently, that real progress is being made. And I've heard about it here today at Hopkins, that I do see that there is tremendous progress going on in the data to knowledge part of this cycle. We do see integrating of clinical data. We do see analysis going on of the variation in practice. There's a lot of enthusiasm for trying to enrich the data with information about genetics or patient-derived information from Fitbits or other kinds of things that patients might report to us. I even see places that are setting up more capacity to do things like pragmatic clinical trials to learn about their practices and their patients. But what is lacking in most environments is really this top half of moving the knowledge to practice, about really figuring out what's the organizational governance structure that can allow us to systematically as an organization decide what the priorities are and how we're going to go about resolving the differences between our radiology departments and our internal medicine departments about what is our recommendation to women about when they should get mammography screening or any other kind of recommendation like that. Right now there are, in many of these large organizations, lots of different organizational responsibilities, and they haven't been merged in a way that has led to a streamlined way of doing some of that. What is the capacity of the organization to update that knowledge into the workflow of activity? How do we think about moving? It isn't enough just to say this is better evidence and then have the clinicians say, yeah, but this is, we have a workflow that doesn't really allow us to incorporate that new knowledge in any kind of way. We also don't have good metrics of knowing how organizations are making progress toward becoming a learning health system, of generating and adopting and applying evidence in a more systematic way. If we had these kinds of metrics of achievement, that might help us know the progress that's being made. And should we be thinking about having our chief medical officers knowing about those metrics, being responsible for them, and in fact being incentivized in some ways to be able to make progress on behalf of the organization toward that. And then being able to assess the value that comes from putting evidence into practice in many ways. The capacity of understanding, is evidence-based practice giving us higher quality at lower cost in the real life settings of what's going on? So these are some of the areas in which I think we have underdeveloped at this point in terms of truly becoming learning health systems, and these are places where health services research could make an enormous impact. And when at AHRQ, we really thought about, how could we help to support this agenda of moving what would a medicine ball research strategy look like? And so some of the things that we thought about were that we really want to work on supporting what we saw as a growing capacity in many health systems, including ones here at Hopkins and at UCSF and so forth, where there is a growing nidus of individuals who are having this organizational framework of what they're trying to support. They're often charged by the CEO to make this thing happen, but they don't necessarily have the workforce or all the knowledge they need to be able to push back against or to be able to support the kinds of transitions that need to be made at the organizational level. So some of the things that we were starting to implement at AHRQ as I was leaving were trying to organize a network of clinical leaders across organizations to share about the kinds of challenges that they are facing to try to make this transformational change in their organization, so they could identify what are the priorities or the skills and so forth they need to be able to bring about that change. We are very much in the role at AHRQ of transitioning some of the support for health services research training to invest increasing amounts of that money in embedded health services training in health systems, so that health services researchers are going to work in collaboration with the health system as an end user to understand the priorities and questions that come up there, and also will work at the interface of, say, clinical informatics, as well as with clinical leaders of the organization, as well as the financial leaders, and understanding how research not only gets done on priority questions, but that is communicated back to the health system in a way where it has an opportunity to bring about change. AHRQ is also making significant investments in data analytics tools to support population management, as organizations are getting that they have incentives to have to do this, but really need more guidance and tools to help them be able to do that. And clinical decision support tools as well, which are really the key for pushing messages back out within the organization about how evidence gets used and incorporated into the workflow of patient care. I think if this is going to happen, it's not going to be enough just for a research organization like AHRQ to try to help stimulate this through research. There's also going to have to be, as there has really been tremendous leadership at CMMI, for thinking about paying for the demonstrated use of evidence in practice, that moving away from volume toward value, and I think this is a key aspect of really making sure that the evidence is utilized. I think for academics to contribute to this process, that we really need to think about whether we have the right incentives in place for promotion to make sure that we are incentivizing health services researchers to work at the interface with end users, to make sure that we are evaluating the impact of our work, not just the creative aspect of it. And so I would start to imagine ways of rewarding people who contribute toward innovation of infrastructure to allow evidence to move to the front lines of care, or individuals who can demonstrate significant contributions to changes in practice and policy, or contributions to improvements in the triple aim. So these kinds of impacts are currently not really weighed in the same way as creativity is in the promotions process, certainly at the institution I know best. But I think all of us really need to think about that. If we are trying to incentivize this kind of impact and change, we need to incorporate it into our promotions process. So there's a lot of moving parts to create learning health systems and to bring about this kind of change. And when I used to go to Capitol Hill in my role as the AHRQ director, they would say, well, isn't there already enough market incentive for these organizations to do it on their own? And I would say it is a lot of moving parts, and that maybe some very wealthy organizations, maybe Johns Hopkins, is able to try to figure out some of this on their own. But I do think that if we leave it to organizations on their own, that there's likelihood of being a lot of wasted effort of reinventing a lot of wheels, and that we may in fact leave behind many patients and individuals who are not able to be cared for in some of our organizations that have the most resources. I think that a strong case can be made for public investment to really coordinate and ensure widespread adoption of transformation toward a learning health system. I think this can happen through things like a learning network of clinical leaders and others across organizations to learn what needs to happen to identify what the biggest challenges are. I think that there can be development and sharing of effective data analytic and decision support tools. And I think metrics of system improvement could be helpful to be able to benchmark across different organizations. And so developing that as a centralized public resource could also be of value. But again, I would welcome thoughts about other things that public investment can help to move and improve our healthcare system by doing it together rather than competing. I think if we're going to do this, we're going to need to have a stable and predictable source of funding for our work. I also think we need to simplify our story. I show it here as a bumper sticker because one of the things I learned when I got to AHRQ was that John Eisenberg, who I've mentioned here a few times, really was a great communicator. And he, in fact, was developing bumper stickers at the time that he was at the helm at AHRQ. Someone showed me one that he had, which was "Put the brakes on mistakes," which was his way of trying to convey the importance of addressing patient safety issues. I'm not saying this is the right bumper sticker, but I think it's a way of trying to simplify our message. I think we all have a challenge to try to do that in health services if we are trying to garner the support of public leaders to continue to invest in our field. So I think we do need to simplify our message, and I will say that a few times I communicated in this way with some members in Congress, and it was remarkable how much they got the story and understood this issue. So it may be an example of something or some way of trying to communicate that. And then finally, I'll say I think it's critical that health services research get its funding coordinated through a single home with a responsibility for the federal investments in health services research. I do think that this diaspora into a multi-headed beast, if you will, has made it very difficult for us to stay on message about what we are trying to accomplish. Now, where that home should be, I think is certainly something that is being discussed right now. I think that AHRQ, as an example, has tremendous experience. But there could be some benefits of considering the relocation that has been raised through the president's budget. And when that is, if health services research were to move, say, to a place like NIH, would it be a less political environment that would be less threatening to the ongoing work of health services researchers? NIH certainly enjoys greater bipartisan support than AHRQ historically has had over the years. And something could be said about facilitating linkages between the discovery functions at NIH with the implementation functions that AHRQ is so uniquely skilled and experienced at. I would say that if this were to happen, that I think it's critical for the field to articulate what some of the key conditions might be. For example, I think it would be critical for the field to have an identity, such as an institute. It couldn't just be that AHRQ is somehow absorbed into the NIH and the functions dissipated in a way that doesn't bring visibility to the field. And so I think that would be a key condition from my point of view. And I also think that there needs to be designated funding with the opportunity to also bring some of the other funding, including the NIH's funding through different institutes, under a common roof so that we could really leverage and give direction to the funding in this field. This is a question that's very much under debate right now, but to me, I guess the main take-home message I would say is health services research needs a home. And while because of my work at AHRQ, I would certainly be biased toward wanting that home to be at AHRQ, I would say that to me, the most important choice is to have a home for our field so that we can be organized in developing our shared story, both among ourselves, but with the key stakeholders who can help to reinforce this for ongoing public support. So thank you very much for the opportunity to share my observations about the field of health services. It was certainly an incredible privilege to be able to be in the position of being the AHRQ director, where I could observe the field and be connected with so many friends and colleagues I've known for so many years. If you ever have an opportunity to serve in that kind of role or to provide public service in that way, I couldn't recommend it more highly. I was sorry it ended the way it did because it was very exciting work, but I'm excited to be able to continue to work along with all of you as colleagues to help to shape the next chapter for our field. So thank you very much, and I'll be happy to take any questions.
If you have questions, please use this mic or the other one over there.
Services research, and I'm also the historian of the Bloomberg School here. I thought it might be worth pointing out that Carr White, when he was here, proposed having an NIH Institute of Health Services Research back in the 70s. When I hear a lot of the things you're talking about, I actually think back to the kind of mothership of health services research, which was the Hill-Burton Act. And it, like you were saying, it started out with a very strong defining story, and it came out of national defense in World War II, and that was the strong impetus. And then as time went on, it got much more diffuse. And I was just wondering, can you think of other examples or models that might help predict where HSR is going?
Well, you know, you're the historian, so you probably know these better than I do, and I really appreciate you bringing up those examples. I guess what I was most sensitive to, as I say, is that when I would visit with members of Congress to try to advocate for AHRQ, that it was rare that a member of Congress could tell me what they thought AHRQ did. That was very concerning for me. You know, I would love to go back in time to understand fully the debate related to the NIH versus separate agency discussion. I do think that it was probably a somewhat different time in the history of our field in the sense that there was appropriately probably concerns that the biomedical model would just eat up what health services had to offer as a different approach. I also think that AHRQ has been unique. It's been both a strength and perhaps an Achilles heel in thinking about that loop of implementation back. Because it's when you go into that space that's when it becomes potentially threatening, how research can be changing what someone is thinking about doing on their own. I think the field of health services research has evolved tremendously. I'd be interested to learn about it here, but in different places that I have visited, I have found increasingly that people who identify as health services researchers are almost as likely to have funding from the NIH as they are from AHRQ or PCORI and so forth. So that in some ways they have gotten over some of the kinds of barriers about if we're not our own thing, that we may be lost in some ways. So I think we are at a more mature place as a field in terms of what our unique skills are that would allow us to potentially be in a stronger position were we now to be absorbed into the NIH. I don't mean to oversimplify that, but I do think it would make sense to me why in the past it would have been perhaps a greater threat than it might be today with regard to that. That doesn't mean that NIH isn't still preoccupied with precision medicine and genetics and so forth, but I do think, and from my own conversations of visits to NIH as the AHRQ director, I was really struck, and perhaps the most poignant conversations were those that I had with Francis Collins and other leaders there, in which I said, you're investing $1.5 billion in health services research. That was originally actually pointed out to me by Francis when he was trying to tell me he was really in charge of health services research and not me. But then I said, do you know what you're getting for that? And there was kind of a long pause. And I said, what are actually your goals for that funding? And I think there was a pretty quick recognition that they didn't have a strong sense of what they were getting for those investments and didn't have a conceptual approach of what they were trying to accomplish. And so I do think that the community, by coming together, perhaps with AHRQ as helping to unify that, could really help to leverage what has been a growth in the amount of funds and to make them utilized in a way that could get us much greater mileage than what we're currently getting from them.
So I have another historical question. So.
Sure. Boy, I'm sorry I'm not a medical historian.
I'm not either. Judy Casper. Nice
Hi, Judy.
To see you, Andy.
Yeah.
And thank you for that talk. So access to care was a core issue of health services research, and you did very important early work in that area. And it seems to me that has not been an area of much interest at AHRQ for some time. Now, maybe you could argue that when we talk about disparities, we're talking in part about issues of access to care. But I would be interested in your thoughts about access to care and where that kind of belongs under the health services research umbrella these days, and where you think researchers with those kinds of interests should be looking for support.
Yeah. So I think absolutely that is a theme that was very much vocalized while I was at AHRQ, and I didn't have to be the person just bringing it up, that there were lots of people enthusiastic about that. I do think the way that work is finding its way back, in a sense, is by the refocusing through payment on populations, right? So that what's happening is that as you make organizations responsible for the health of populations, not just who they're seeing, but increasingly on the geographic basis and different models and so forth, then access starts to become a key issue that is part of the business model, if you will, for these organizations. So I think it's a key aspect. It is also captured in what you're talking about, the work on disparities. That part of this is, what I learned at AHRQ, which I'm sure many of you have recognized, that there's been a constant reframing of issues, sometimes in response to political issues that are raised about interest or disinterest around certain things. Something I should have said about the AHRQ budget for those who may not know this, but it's not, when I showed that there's $334 million appropriated, say, for AHRQ in 2016, that's not just a single lump sum. There are actually earmarks within that budget that specifically say how much for the MEPS survey, how much for the U.S. Prevention Services Task Force, how much for patient safety. There is there's a leftover portion that is discretionary related to health services research, investigator-initiated grants, but it's pretty carved up. It's pretty teeny. That's right. And so, part of the issue is absolutely, there's an enthusiastic group of staff very interested in the access issues. I think it is fundamental to health services research activities to me, the back door way back in was through the work on population health and as well as the disparities work. So I don't think you have to worry that that isn't a theme that is of great interest. Part of what you also see get articulated most strongly, things like the patient safety, is because I think those are themes that have, for whatever reason, stuck most strongly with members of Congress. It's a story that they can sort of get in some ways, and has been clear for them. The access issue does resonate to some extent, particularly for members of Congress in rural areas. I have found concerns about there being an inadequate workforce in rural areas. Every senator cares about rural issues because they all represent some rural parts of their state and so forth. So that would be another place that I have found that there's a lot of traction around that. And there's magical thinking that telehealth is going to fix all of the access problems. That doesn't mean we don't investigate that, but that's another place that it shows up. Yeah.
Right. Thanks for such a great talk, David Bishai from the Population Family Health Department. Your Moneyball analogy raises the real difference. It's that the players aren't all playing the same game. We're not keeping score the same way.
Right.
The orthopedists and the radiologists and they don't share the same goal. And in terms of even the AAA, we're in a school of public health.
Right.
So we only really care about population health in the big the 300 million or
Sure.
7 million population, which I think was what Francis Collin should be tasked for. And as we get AHRQ functions into NIH in public health, we want that to be the game, which is the health of the people.
Yep.
And then medical care is too narrow a focus for AHRQ, isn't
Yep.
it?
Yep.
We really want to talk about things that happen outside of the medical care or the NIH enterprise. So how can we play that game? I think that's the game that Congress ought to care about, which is, are we getting healthy for the money, for all the money?
Yeah, no, I think that's absolutely right. I think partly, and this is a strategy that as a community we need to think about, which is, do we build out from what people recognize, which is this kind of biomedical model, and start layering on these additional pieces related to public health functions and systems and so forth. But I couldn't agree with you more. I mean, I think it's so absolutely essential. What I think what's unique, though, that I was trying to highlight is that I do think the formation of these organizations, like Hopkins Health and UC Health and so forth, is changing a dissemination pathway of evidence that has not until now really been available to us. So, when AHRQ moved away from being able to issue guidelines and was just in the evidence synthesis business, it then started to partner with specialty societies and said, hey, here's the evidence related to heart disease and so forth, go off and make a guideline. And what happened, of course, is what I showed you, which is the radiologists made their guideline and the internists made their guideline and so forth, and basically tribalism was on display with great regularity. I think the organizations that are being formed, there's an opportunity for us to think about how to utilize them and to bring the population mentality associated with those organizations to get them to think about these larger issues that you're talking about. And I do think, yes, of course, they will start first with the patients that they're seeing as their population, but there are ways to use the payment tools to, in fact, make them responsible for the geography's health. And again, I learned as already part of my visit here, the degree to which that's starting to happen, here in Maryland to some extent. And so I'm somewhat hopeful about being able to move in the direction that you're talking about. I think that's absolutely right, but I think we have to empower organizations to first deal with getting everyone to play the same game. And I do think these organizations, they're not doing it yet, but there's the potential there that wasn't possible by just relying on specialty societies to be bringing the message inside the organizations. Because once they got inside, they hadn't harmonized their disagreements in any kind of way. And now we need to support that possibility.
Andy,
Yeah.
John Bridges,
Hi.
I'm a health economist in the department.
Yeah.
The Moneyball analogy brings the idea of incorporating very young people with very little training with new ideas. And my observation of particularly health services research in the US is it's a old person's game. There's a cadre of very successful, very older people. It struggles to find really innovative, really successful people, even in their 50s, let alone their 40s. And I've got people sitting here in their 20s thinking, oh, you know, to break into the game, it just takes so long.
Yep.
Is that a shortage of funding? Is that how much it takes to actually have an impact? What strategies do we actually need to bring young, innovative people and empower them to actually have change? Is that different types of networks? Is it different types of trainings? Is it a more stable grant foundation?
I think that's a really interesting question, and you know, I think part of why it looks the way it does right now is what you're getting at, which is that the funding has been relatively scarce, and so it does take seasoned people who are really good at being able to do that. Having said that, I have seen in my own institution and when I've gone around to visit, the change in the payment models and in the movement in the environment has attracted a lot of young people, certainly in San Francisco, really thinking about healthcare being delivered in a different kind of way and having different kinds of aspects of it measured and what progress looks like and so forth. I don't think the infrastructure is completely worked out yet to how to support those jobs and what that's going to look like, but I do think the health systems are starting to realize maybe we need some of these kinds of people to make the kinds of transformation we need to make. It can't purely happen on kind of the old research model of you apply for a grant and a year and a half later after 2 revisions you get it. It has to happen in a much more rapid kind of way, and it's going to take different kinds of investments, including from the organizations themselves, really having an interest in seeing this new knowledge being generated and applied and so forth. And so I do think that's an opportunity. It was interesting, I mentioned I was up at Penn a couple of weeks ago, and I was struck by one of the things. I met with David Ash, among other people, and David is running he's like their chief innovation officer or something, and he described that one of the main things he thought he was doing at Penn was, some of it was they were innovating things, but it was mostly his entire staff. He had now, I don't know, about 60 people, and none of them were over the age of 30. He said, the organization is changing through something like this, where young people who might otherwise have gone to work in Silicon Valley find health system challenges interesting, and we're kind of changing the culture of it's hip and cool to work on, health system innovation. So I do think young people will figure this out if we make sure there's enough, way to help them be supported. It can't be the pure grant model is what I think your comment really gets at. I agree with you. We need to have either more rapid ways of providing that funding, and the organizations themselves, I think, need to get involved in that process as well. But would love additional economic stimulus ideas. Oh, Karen.
I liked a lot the Moneyballs bumper stickers. So I think that idea of data analytics and what that can bring to the performance of the health system, health outcomes, is a very exciting way to sell health services research in the future. On the other hand, I must say I have some fondness for the diaspora and some discomfort with the thought of consolidating all health services research within NIH. In the current budget environment of severe cuts in funding and the lack of an NIH leadership understanding and commitment to health services research, it just seems like an easy way to wipe it all out. So keeping a PCORI and a CMMI and VA are different NIH, different sources, seems a better strategy for me right now than doing this, even though I can appreciate the logic of it. I was intrigued by, you said, is it AHRQ or is it health services research that leads to the political unpopularity or backlash? And I think it's the type of research. So if you're talking about access, equity, disparities, the uninsured, Medicaid, policy, none of those words seem to be in your slides. And I think that's where you get the backlash to AHRQ specifically, and where private foundations have kind of moved in, because it has been hard to get government funding for that. The second area is, as you mentioned, the guidelines, but I would say payment and delivery system reform generally. When you talk about overuse or overpayment a lot of vested interest in the sector get very unhappy with that kind of work. So certainly CMMI has been able to do a lot on that front because they can show that it affects the trust fund and Medicare outlays. So, to have $1 billion committed over 5 years to that wouldn't have happened, I think, if it had been in AHRQ. Instead, the least controversial have been the patient safety. You mentioned telehealth, prevention, maybe diffusion of effective clinical practices. Everybody wants better outcomes. So I think given the political sensitivity of different types of health services research, being able to nest it in an organization that can carry that forward has some appeal.
Yeah, so I fully appreciate your arguments. The only thing I will say is that you never know whether you're making in policy, it's always about what is our ideal outcome versus what is the best choice among some bad options for us. I think it's pretty clear that the politics are both challenging for AHRQ. They're extremely challenging for PCORI in the near future. I think it's hard to identify a lot of champions currently in the Congress that favor comparative effectiveness research. The payers for PCORI's work, which are essentially the health plans. When I was sitting on the governing board, they came in and presented to us, and to say that they were angry would be an understatement about what they thought was the return on their investment and how that work had actually led to, what they were looking for was tell us what things we don't have to pay for in our health plans, and did not feel like that was being delivered to them. So I guess what I would just say is, to me, the forecast for some of these different camps of supporting health services, it's not uniquely AHRQ. I do think it could affect each of these potential camps. And part of what we have to make a judgment call on as a community is whether we might find a safer harbor in a place like the NIH. It would not be I would not have put that forward as my first choice, but I'm trying to also evaluate some of the risks of what the environment looks like as a whole for the community. And the second thing I want to get at, which I think is critical, is that I think these things that you characterize as potentially, less popular or more controversial, I think it's critical the field continues to work on those, but that we need to do that from a position of strength, of having provided to key stakeholders things that they really see of value. And I do think that there is potential with activities like the work on the learning health system to get entities like the AAMC or the AHA or other entities that could really speak on behalf of the work of our field in helping them to make progress toward their own goals, that could provide some of the cover that patient safety does a little bit of right now for AHRQ, and maybe get more stakeholders engaged in supporting the field as a whole, so that we could continue to do the broad range of things that I think are so critical for the field to do, but that we need to be able to have some marquee successes and arrangements with stakeholders that I think could help us get the safety to be able to do that in some ways.
This has been extraordinary. Unfortunately, there's classes that occur here, and someone needs to get in this room. So I'd like to thank Dr. Bindman very much for his honesty, generosity, humor,